Yeah.
Good afternoon and welcome everyone to the surgical illustration presentations by the class of 2025. I'm very happy to have here in the audience our faculty, our first year students, friends, people who have helped the students in the operating room, alumni, and family members as well. And we also have a YouTube audience. So what you're about to see are 14 surgical presentations by students who have spent a lot of time in the OR. They've seen dozens of procedures and they've selected two that they're going to show you. They've illustrated the steps of the procedure in pencil sketches, and then they have selected one or more of the images to illustrate in full color for final pieces. The assignments include illustrations for a journal layout, as if the pieces were going to be in a surgical journal, or for slides. So you'll see a variety of those. They also have an additional assignment where they illustrate the same procedure for a lay audience, either for patient education or to describe the procedure to a general audience. So you'll see a few of those images as well. But the main procedures, the main images are to explain to surgeons how to perform the procedures. The students will go through their first surgery, then take a break for questions and comments. We love questions, and it's a great opportunity for the students to field questions from an audience. Then they will do the second. Oh, if you have a question, Maggie has a microphone, and so that the folks on our virtual audience can hear the question, we would ask you to wait till you get a microphone. And then they'll present their second surgery, and we'll go on to the next student, and we hope that you can all join us for a reception at the end. We'll start with our first student, Talia Mastalski.
Good afternoon, everyone. My name is Talia Mastalski, and I'll be presenting an illustrated summary of a leg amputation revision with the placement of a compressed osseointegration transfemoral implant. This surgery was performed by Dr. Brock Lindsay and Dr. Lily Mundy. I want to thank Dr. Lindsay and his research associate, Nicole Liddy, for their feedback in creating this piece. For a bit of context, when you think of a limb prosthetic, you probably picture the traditional socket-mounted prosthetic, as depicted here in this graphic created for a lay audience. However, users of this type of prosthetic have a lot of discomfort with the design, owing in a large part to improperly aligned bones and skin irritations from socket pressures. Osseointegrated prosthetics resolve these issues by being directly implanted into the bone. There are several types of these prosthetics on the market, but I observed specifically the implantation of the compressed device from Zimmer Biomet, which is currently in clinical testing here at the hospital. To begin, the incision was made across the surface of the residual limb. In this case, it was the right upper leg over a previous incision. The distal femur was then exposed by splitting the myodesis of the previous muscle closure, and then resected by approximately 2 centimeters for a cleaner cut edge. A canal was reamed through the center of the femur using a special compressed triple reamer to allow for the implantation of the anchor plug. The plug was inserted into the canal, and a drill guide was attached and aligned to the plug holder to facilitate extra stability. 2 short drill bits were inserted through the femur to maintain alignment of the anchor plug during pinhole drilling and transverse pin insertions. A face planer was used to create a clean beveled edge for the transdermal compressed spindle attachment, which was slid over the implanted anchor plug traction bar until snugly fit. With the light tightening of a nut onto the spindle, bevel washers were compressed until the compression cap was released and the spindle itself was firmly compressed against the femur. The Osseo-T spindle collar could then be set and impacted onto the spindle and secured with its plug. To begin closing the wound, a new myodesis was created by suturing muscle flaps through circumferential holes of the Osseo-T spindle collar. Hamstring and adductor muscle flaps were secured to the posterior side of the collar, followed by the quadricep flap to the anterior portion, The quadriceps are then longitudinally split and levered over the spindle's end, allowing the posterior portions of the flap muscles to be sutured posteriorly. Finally, the gracilis was advanced distally and laterally to provide support and coverage medially. The stoma for the abutment was then created through skin incision, and intervening subcutaneous tissue was removed. A thigh-plasty and several layers of stapling and suturing secured the tissues and removed any excess bulk to create an appropriately sized and balanced residual limb. Finally, the transdermal compress adapter was impacted over the exterior spindle taper and secured with its adapter plug. And here's a look at the patient's legs before and after the transdermal revision with the prosthetic attached. For my fully rendered piece, I chose to illustrate the main steps of the procedure, starting with reaming the femoral canal, implanting the anchor plug, and attaching and compressing the spindle. I also illustrated an overview of the myodesis creation and included the pre- and post-op appearance. Thank you, and I'll now welcome any questions or comments. And please wait for the mic to start speaking.
Thank you for this presentation, Talia. I think what's most effective about your sketches and how you one of the pieces gave us some perspective from the same view throughout, and we were able to understand all of the steps in surgery, hardware, this kind of better feeling for start to finish. I applaud you for beautiful work at the end, but also the sequential process that you worked out.
Thank you, Tim.
This is a really ambitious first surgery, so can you talk a little bit, describe to the audience how you use some of your 3D skills to create these pieces?
Yeah, so all of these devices, such as this one and especially this one, I didn't have access to the actual physical device. I had access to a manual, so I used the manual to create very rough 3D models in C4D, and from there I was able to add positioning and lighting to the project, figure that things out through there, and then I was able to add in the details with illustrating over top.
Really fun to look at your species again, so impressed by everything that you put into this. I think it's alluded to environment feedback from opportunities and really showing so it's hard to see completed real sort of choosing on steps and so on and operating step procedures. It's fantastic. Back out to me.
Yes. More.
Yeah, I was just talking about a hierarchy of information, the flow of the story, led your patients to reverse that shape. It's just a really
Thank you, Lydia. All right, thank you. My second surgery is of a left upper lobe segmentectomy, as performed by Dr. Stephen Yang. I'd like to thank him for all of his feedback while creating this piece. A segmentectomy refers to a robotic procedure to remove portions of the lung that contain cancerous tumors, in this case, apical, posterior, and anterior segments of the left lung. On the right, I have illustrated the nodule within the segments that will be removed. On the left is the location of the nodule within the chest cavity and its relation to the robotic ports created. The camera was placed in port 2. The left lung was also collapsed during the procedure, as natural movement of the lung from breathing can complicate precise manipulation of the tissue. For each of the following steps, I have depicted both the operative view, so the view of the surgeon through the camera, as well as a diagrammatic anterior view to better understand what segments are being removed. It is also important to mention here that within the pulmonary circulation, it is convention to illustrate arteries as blue and veins as red. To orient yourself in the operative view, the left lung is in the upper left, being elevated medially onto the heart. To begin the procedure, after entering the pleural space, the posterior pulmonary branch was divided and stapled, preserving the lingular branch. This was followed by the removal of the left 10 and 11 lymph nodes to assess for cancer. The apical branch was then dissected and stapled in a similar fashion. The lung was then retracted posteriorly to access the anterior hilum, the heart now visible at the bottom of the screen. Branches of the left superior pulmonary vein to the anterior and apical posterior segments were divided and stapled, again leaving the lingular branch intact. The lung was retracted back anteriorly and the left upper lobe bronchus was divided. The distal bronchus to the apical posterior and anterior segments was cut to expose the anterior pulmonary artery branch obstructed from view. Cutting the bronchus allowed for the anterior branch to be divided and stapled. The cut end of the bronchus could then be stapled and the proximal bronchial stump was removed. The lung was then reinflated to test and make sure there was no air leakage among the stapled vessels. Once confirmed, the apical posterior and anterior segments were divided with the stapler. Additional lymph nodes from stations 5 through 7 were identified and removed as well. Finally, all the specimens were placed in an endobag and removed through the air seal port site. My final illustration combines the steps of dividing the anterior pulmonary branch and the removal of the proximal bronchial stump. The anterior view highlights the anterior branch as well as illustrates the previous divisions. Thank you for listening. I will now take any questions.
Talia, this is a great job. I hadn't seen this in a while, and I just wanted to compliment you on both seeing the interior view and the operative view together, but also in your final. I really love the changes that you made with the color. It's just really, really clear and very three-dimensional. Yeah, they just correlate so well together. So.
Thank you, Jenny.
Again, fantastic job. I think this turned out wonderfully. This is just actually a small comment. We made a lot of improvements since our last critique. I think the inset is now read very clearly. One thing I would still do is just darken the line work in that inset a little bit because it's the value range is very similar to the background right now. Okay. So especially where I can see the pulmonary artery closer in place, so just keep that line work and increase it the darkness by %.
I could do that. Thank you. All right. Thank you very much. Now it's my pleasure to introduce the next artist, Kavita Subramanian.
Thank you, Talia. Good evening. My name is Kavita Subramanian. My first surgical procedure is brow ptosis release. I would like to thank Dr. Kofi Bohaney for his informative feedback for these illustrations. The procedure contains 3 smaller surgical procedures to relieve symptoms of muscle weakness following Bell's palsy on the right side of the patient's face. The patient has spasms and hypertonic muscles on the right side of the face with 3 symptoms. A drooping brow or brow ptosis. The first procedure is the release of brow ptosis. A narrow palpebral fissure or narrow eye opening caused by the lower eyelid at a position higher than normal. The patient's eye closes upon smiling. The second procedure to correct the lower eyelid is a selective myectomy with terminal neurolysis of the orbicularis oculi muscle. And the third symptom, the patient has an incomplete smile due to a hypertonic depressor anguli oris muscle at the edge of the mouth. This will also be corrected with a selective myectomy and terminal neurolysis of the affected muscle. The procedures begin with lidocaine injections in these sites near the eye and then the mouth. Lidocaine is not used for the forehead incision to correct brow ptosis. I will focus on the first 2 procedures near the eye. To release brow ptosis, an incision is made deep to the deep temporal fascia to elevate it with blunt dissection, taking care to preserve the temporal branches of facial nerve or CN7. As the arrow in this next figure shows, the arcus marginalis is released along the orbital rim to free the lateral and temporal aspect of the brow. The brow is then suspended superiorly with 2 interrupted sutures, taking 1-inch bites and secured to the deep temporal fascia, and the scalp incision is closed. In the second procedure, after the injection of lidocaine, a subciliary incision is made to access the terminal branches of the nerves of the orbicularis oculi. The muscle is isolated from the skin and fascia. A section of muscle, 1/8 of an inch wide, is excised and a cautery used at the end for hemostasis. The skin incision is then closed with plain gut sutures. The symptoms of Bell's palsy are alleviated as a result of the procedures as shown in these post-surgical illustrations. These illustrations are designed for a hypothetical journal. These are my final rendered illustrations for the elevation of temporoparietal fascia and suspension of fascia with sutures for the release of brow ptosis. I can now take any questions about the procedure.
You made some really positive changes on this decision. You want to mention that. I think that this is a seemingly simple procedure, but I think much of the dosing levels that we're trying to show actually quite good. And I just wanted to compliment you on some very positive changes.
Thank you, David. All right. Thank you for your feedback. My next procedure is the repair of the mitral valve, which is the valve between the left atrium and left ventricle of the heart. I would like to thank Dr. James Gammy for his wonderful feedback for these illustrations. The procedure alleviates symptoms of mitral valve regurgitation, which causes shortness of breath with exertion or when lying down, and tiredness due to backflow of blood from the faulty valve. This is an overview of the procedure for a general audience with before and after pictures. The procedure involves 2 parts. The first, the repair of the ruptured chordae tendineae, which anchor the mitral valve to the ventricle. And second, insertion of a synthetic ring which reinforces the fibrous frame of the mitral valve to ensure longevity of the repair. The procedure begins with a midline skin incision over the sternum from the sternal notch down to the xiphoid process. This is followed by a sternotomy. Next, the sternum is retracted. The pericardium is incised down the middle, reflected, and sutured away to expose the heart. Cannulation stitches are placed on the aorta. It is cannulated and cross-clamped. Cannulation allows the blood to be diverted away from the heart while the procedure is performed, toward instead a heart-lung machine. The next image will be from the patient's right shoulder looking toward the legs for viewing the interatrial groove. The inferior vena cava and superior vena cava are also cannulated in this manner and clamped as shown in the figure on the left. The surgeon then locates the interatrial groove between the superior vena cava and the right pulmonary veins. This would give them direct access to the mitral valve through the left atrium. In this image, the atrial walls are retracted to show the posterior leaflet prolapse and the thickening of the leaflet that caused the regurgitation. Around 17 annuloplasty sutures are placed in preparation for the annular ring to reinforce the fibrous frame of the valves, and they begin as shown. The needles are left attached. Next, this cross-section shows the placement of the ruptured chordae tendineae with the replacement of the ruptured chordae tendineae with Gore-Tex sutures. 3 to 4 pairs are placed on either side near the center and looped around the papillary muscles twice, as the next slide will show. This is a sequence of each choroid tendinae replacement, with a double loop around the papillary muscle. The annuloplasty ring or synthetic annulus is sized and inserted using the sutures placed earlier. The synthetic annulus is tied down. This cross-section also shows that the posterior leaflet will extend lower than the anterior leaflet after the chordal replacement. The sternum is wired together with sternal wires. The fascia is sutured, and the skin incision is closed with subcuticular sutures. This is my rendered illustration of the chordal replacement in the mitral valve repair. Thank you kindly. I can now take feedback and questions. You're welcome.
This is so lovely, and I felt that sketching and the sequential representation of action was exceptional. Procedures and process. I think that translates very well to this. The only thing that stands out is how I might suggest what it would be like if you quite fully render cardiac muscle. I think that it would tell a consistent story. You can still place the valves and the elements within that anatomical without competing with the other lovely pieces that are doing that. So very, very nice.
Thank you.
Yes. It was joy to work with you on this project. I think that serve the audience well with the sequential passing of sutures. That is the story of the all model approach for Dr. Kim. I can agree with Dean about the heart muscle has not been a bad move, so our focus. One comment I would make is that new values are not legible from the audience, and they're important to be part of. Nice job.
Thank you for the feedback, Tim. Thank you so much. I would now like to introduce my colleague, Abigail, for the next presentation.
Hello, everyone. My name is Abigail Rump, and today I will be presenting on my two surgeries, the first of which being a right thyroid lobectomy. So I observed a right thyroid lobectomy with Dr. Lila Morris-Wiseman. Thyroid lobectomies are typically done to treat hyperthyroidism or to remove a mass found in a thyroid lobe while still preserving the hormonal function of the thyroid. So the procedure first begins with a 4 to 6 centimeter incision, about 1 finger breadth or 2 centimeters above the sternal notch, ideally in a natural skin crease for cosmetic purposes. An incision is made through subcutaneous tissues in the platysma muscle with scalpel and electrocautery. Subplatysmal flaps are raised using skin hooks, and a bovie is used to incise the platysma. The deep cervical fascia in the midline between the strap muscles, called the median raphe, is incised to separate the sternohyoid muscles, exposing sternothyroid muscles and the fibrous capsule of the thyroid gland. The sternohyoid and sternothyroid muscle are dissected away from the anterior aspect of the right lobe, then retracted laterally. This exposes the right lobe of the thyroid. The carotid sheath is then dissected to expose the common carotid artery, internal jugular vein, and vagus nerve. Strap muscle and tissue on thyroid gland and the carotid sheath are cleared with gentle blunt dissection. The thyroid is then rotated medially in 5B to expose more of the surgical plane. The inferior thyroid artery is used as a landmark to identify the vagus nerve, which is confirmed via a nerve stimulator. In 6A, the thyroid is then retracted anteromedially to visualize the superior portion of the lobe, seen with the superior thyroid artery and vein. From medial to lateral, the avascular space of Reeves is opened. This critical landmark, which can also be called the friendly space of Reeves, is a safe plane to dissect in to avoid damaging the external branch of the superior laryngeal nerve. The nerve is then dissected from medial to lateral, staying close to the thyroid and separating it from the muscle. Once dissected, it's safe to ligate the superior thyroid artery and vein. The edge of the superior pole is identified in 6B, and the superior pole vessels are ligated with sutures and electrocautery in 6C. The superior pole is now free and mobilized. In 7A, the thyroid gland is pulled laterally to look at the underside of the inferior thyroid. The lower parathyroid gland is identified on the thyroid capsule, which will serve as a landmark to identify the directly posterior right recurrent laryngeal nerve. In 7B, the inferior parathyroid gland is dissected away from the thyroid capsule. The tertiary branches of the inferior thyroid artery are then divided with sutures and cautery, preserving the parathyroid's vascular supply. In 7C, at the upper tracheal rings, the recurrent laryngeal nerve embeds itself into the ligament of Berry, where the thyroid is firmly adhered to the trachea. The ligament is ligated and cauterized to protect the recurrent laryngeal nerve. Once ligated, the thyroid loses its adhesion to the trachea and is much more maneuverable. The thyroid is then retracted medially, exposing the trachea. The isthmus is removed off the trachea via electrocautery, freeing the right lobe for removal. The platysma is reapproximated using a running locking stitch, and the skin is closed with a subcuticular stitch. For my final illustration, I chose to illustrate step 7A, where the thyroid is pulled laterally and the parathyroid glands are identified. I chose to illustrate this step for a journal where it shows why it's important to preserve the parathyroid glands and why the vasculature and how the vasculature is ligated and kept. I welcome any comments or questions on my final illustration.
As I watched you listen to you go through this surgery, it's really fun to see you sketches. What I found is that going through and showing steps, you did a wonderful job setting up the hierarchy and taking us through almost an animation where some of the steps you do, some you pull back out. So you did two things. You kept it aging, not all this is the same thing. It's in a lot of sound. And I had no problem going from step to step, had enough of the previous step.
Thank you, David. I appreciate your help with the project. It was very helpful going to the lab and all, so thank you.
You're so nice. I'm so sorry.
Oh my gosh.
I really like your use of grayscale here. I was wondering if you could tell us more about why you made that choice.
So I wanted to focus on the vasculature of the thyroid since that's a pretty critical step throughout the surgery. It's okay. I know you called me Hannah. I forgive you. So I wanted to focus on the aspect of the vasculature and highlighting how it's connecting to the parathyroid glands. And like I said, this step is really critical because preserving these glands means that the body can maintain the calcitonin levels and there's no other issues that arise from having them be damaged or removed. So I used it to kind of highlight the vasculature and kind of fade out everything. I did play around with coloring it. I originally had the thyroid as like a bubblegum pink, but it kind of took away from the message I wanted to do with this step. So I just kept it black and white. And I think it works well with just having the vasculature colored. I am. It's for print, so it would be in a journal as part of a surgical atlas or a procedural step-by-step.
I must say, the blueprint treatment of your sketches and the story, I can recommend, and I can do the standalone by myself and you can do that version of the final would also be good. That was refreshing to see, and it would also be good. So thank you.
Thank you, Anne, for your kind comments. I had David in my mind the whole time while I was making my sketches, hearing him say make it like an animation, so I have him to thank for that. Oh, one more. So popular. So she asked if I used any 3D models for this. I did. I also used real live cadaver models. Thank you, David. So this area, so to note for this surgery, the operating plane is really small, so it's really, really difficult to see what's going on. So David and I elected in my sketches and for the final to open up the operating plane more so it's clear what's actually going on. Because if I had it as the actual size, everything would kind of be under the skin and it would be really difficult to follow. So that's where the aspect of make the sketches like an animation and make it easy to follow, because this is a hard surgery to observe in the first place, and sketching it was a nightmare. So yes, I used a lot of references. I used a lot of models. Going to the lab with David was very helpful because I was able to actually have an open plane and play around with the musculature. And there was actually a thyroid still left in there too, so that made it really easy to move things around. So yes. Thank you. For my second surgery, I observed a hysterectomy preserving the left ovary with Dr. Rebecca Stone. The ovary is typically preserved during the procedure to maintain hormonal function, as well as reducing associated risks like osteoporosis or cardiovascular disease. The procedure begins with the placement of surgical ports and the insertion of instruments. Before docking the robot, the abdomen and pelvis are visualized to identify key anatomical landmarks and to confirm that there's no unexpected findings or complications in the pelvis. The uterine manipulator is inserted to mobilize the uterus, providing control over its position throughout the surgery. It also protects the vaginal wall during the colpotomy by supporting the uterus and keeping the vaginal tissues clear of the surgical site. In 3, the camera is looking down towards the patient's feet in an operative view. A window is created in the mesosalpinx to access and isolate the ovarian vessels. This step preserves the ovarian vascular supply and branches, which is critical for maintaining perfusion to preserve the ovary. Bipolar energy is used to minimize thermal spread during dissection. In 4, the mesosalpinx is further divided, taking care to preserve the integrity of the ovarian branches. This approach reduces the risk of ischemia and preserves the ovary's function. In 5, the fallopian tube is moved posteriorly to access the round ligament. The round ligament is then divided using bipolar cautery. This facilitates mobilization of the uterus and provides access to the retroperitoneal structures, including the ureters and uterine vasculature. The broad ligament is then dissected to create anterior and posterior leaflets, allowing for better visualization of the underlying structures. Once the leaflets are separated, the vascular pedicles containing the uterine artery and vein are exposed and clearly observed. In 8, the uterus is flipped posteriorly to apply tension to the pedicles to make dissection easier. The uterine vasculature is then skeletonized, ligated, and transected using monopolar scissors. By isolating these vessels, the risk of back bleeding is minimized. The right ovary is then separated from the suspensory ligament of the ovary since it will not be staying behind. In 9, a circumferential incision is made at the cervicovaginal junction, separating the uterus and cervix from the vaginal vault. The bright teal color of the colpotomy ring on the uterine manipulator serves as a visual and tactile landmark during dissection, which facilitates separation. In 10A, the uterine manipulator is removed, and in 10B, the uterus is extracted vaginally. This is done to minimize the size of the abdominal incisions on the patient, enhancing postoperative recovery. For closure, the vaginal cuff is closed using simple running barbed sutures. Closing the vaginal cuff involves suturing both the vaginal mucosa and underlying fascia to reinforce the pelvic structure. In addition to this, incorporating the uterosacral ligaments into closure further stabilizes the pelvic floor, reducing the risk of postoperative prolapse. This is essential for maintaining long-term pelvic floor integrity and function. For my final illustration, I chose to illustrate step 4, as preserving the left ovary was a unique and crucial step for this procedure. In the illustration, the mesosalpinx is divided via bipolar forceps following the ovarian artery and vein, preserving the ovary's vascular supply. I welcome any questions or comments regarding my illustration.
Really wonderful work that we do. This anatomy is under illustrated. You did a great job as illustrations to repetitions. I had a sort of an anatomical question. So, I saw that you said this to the two ovarian ligament. I was thinking that this is Hopkins is sort of an extension of it. Is that correct?
Yes.
Okay, in that case, you can see you have an incision for this esophagus. You can really see it on the proximal looking too. You show it just wrapped around to the posterior surface.
Yeah.
I would probably continue that, even though I'm sure it would be possible that it would disappear. I would just add it coming down on the distal looking too, just to highlight the continuity between the students.
Okay, I could do that in my next round of revisions. Thank you.
There's so many things I love about students.
I already did one for you. I'll do another one.
We put the 6.
Yes.
So I just think how you illustrated this is just fantastic, because I don't think that I've ever seen anyone try to illustrate the retroperitoneum and sort of what happens here and sort of the layers, that you have to get through to, identify the ureter, and how that, sort of through the round ligament is, it's like separated, but we haven't gone through the anterior, we've gone through the neck, there's like so many parts of the surgery that I do, like I see here that I've never seen illustrated before, and it's really amazing. And then I also really love when you made the pulpotomy. I also have not seen that illustrated as accurately as this, and I think that's really good. And that one before at 8, that way you draw the vessels there is like really very accurate as well, and beautiful how they're, it's one of the only besides the splenic artery, like early artery in the body, is you really get that feel of how they're tortuous vessels. And I also like the action that you get through the robotic instruments, and how in your final rendering you can appreciate the cautery effect of that bipolar, where you can see the thermal injury to the tube along that incision line. And I think that's why it's so important for the way that you illustrated this. People never pay attention to this part of it that you really hug the fallopian tube, so you limit that thermal injury, through the vasculature and into the solving. So it's just a terrific job. Congrats.
Thank you so much, Dr. Stone. I had an excellent surgeon to help fact check my drawings.
The main image is very beautiful, well done. Compliments you on your sketches, on your tissue reaction. It's the fewest lines and accent lines, and really shows that you really understand what happened at the same time when the stretches gathered, and use line often to incorporate done.
Thank you, Tim. I had an excellent OR instructor for OR sketch. Oh, spoilers, sorry. I would now like to introduce my classmate, Terry Nguyen.
Thank you, Abby, for introducing me. Hello, everyone. Thank you for being here today. My name is Terry Nguyen. For my first surgical illustration piece, I observed an Orchiopexy procedure with Dr. Charlotte Wu. Orchiopexy is a surgical procedure that moves an undescended testicle into the scrotum, and it is typically performed on patients between the ages of 6 months and 24 months. On the following slide, which depicts anatomy before intervention, I chose to compare normal testicle position and abnormal testicle position in relation to the inguinal canal. During an orchiopexy, 2 incisions are made, the inguinal and scrotal incision. The testis is delivered to its appropriate position by the surgeon, and patients are expected to recover within 2 to 4 weeks. As previously mentioned, the surgery is normally performed on patients under 24 months. However, I observed a case performed on a teenage patient and based my illustrations on that. So let's get started. A surgeon first palpates and makes an inguinal incision. A 3-centimeter incision is made on the skin overlying the external ring. First, Scarpa's fascia is divided, and the undescended testis can be visualized. Then the external oblique aponeurosis is incised down to the external ring in the direction of the striations. The testis is elevated out of the wound. The gubernaculum is divided to release the testis from its scrotal attachment to initiate the spermatic cord lengthening. Following this, the hernia sac is divided. Proximal cauterization is used to free the tethering of the cremasteric and spermatic fascial fibers. Care was taken to preserve the vas deferens. These steps together reduce the tension and allow further mobilization of the cord. Once sufficient length is achieved, a finger is placed from the inguinal incision into the hemiscrotum to create a tunnel for the testis into the scrotum, and a scrotal incision is made. Next, a curved hemostat is delivered from the scrotal towards the inguinal incision, and the testis is grasped and pulled within the tartose pouch, and the testis is then sutured into position. The scrotal skin is closed with buried interrupted stitches. The external oblique fascia is closed with interrupted stitches and scarpas with running. For my final illustration, which is laid out for a journal figure, I chose to render division of the gubernaculum and hernia sac. This concludes my first presentation, and I welcome any questions or comments.
Yeah, I want to compliment you on your sketches. It led to really a sensitive approach and fine language. I think what's striking about this particular is that you focus the viewer by limiting the center of action and you treat everything else and working this and out and softer and treat. So the instruments are acting, showing the technique from specifically to that.
Thank you very much, Tim. All right, moving on then. Any last comments? All right, let's go on. For my second surgical illustration piece, I observed a radical extraperitoneal prostatectomy with Dr. Christian Pavlovic. The extraperitoneal approach of this surgery allows access into the pelvic cavity without even entering the abdominal cavity. In this image, the patient's feet are pointed into the slide. The surgeon first removes the fatty tissue overlying the endopelvic fascia and prostate. Next, the lymph nodes are examined and a bilateral pelvic lymphadenectomy is performed using clips for lipohemostasis. Care was taken to preserve the obturator nerve and vessels. The endopelvic fascia and puboprostatic ligaments are incised to free the prostate laterally and apically. The dorsal venous complex, or DVC, is ligated with an endostapler. Bladder neck transection begins with the identification of the boundary between the prostate and bladder. The surgeon relies on the tenting created by applying tension to the detrusor muscle as well as the typical hourglass shape to identify this boundary. A combination of electrocautery and blunt dissection is used, and the inner mucosa of the urethra is visualized. A Foley catheter is used to elevate the structure. The anatomical groove between the bladder and prostate is further dissected. Once the longitudinal fibers are transected, the ampullae of the vas and attached seminal vesicles are identified. The vas and seminal vesicles are divided respectively. The posterior aspect of the prostate and the non-VA's fascia are incised transversely with pedicles divided laterally. In Figure 7, the apex of the prostate is dissected, freeing the prostate from its attachments. At this point, the prostate is bagged and removed from the operative view. Vesicourethral anastomosis is performed using the Van Vethoven technique to create a connection between the urethra and bladder. A double arm suture is carried out in both the clockwise and counterclockwise direction. I chose to render the previously discussed slide as my final piece. This concludes my presentation, and I welcome any questions or comments. So the question was, what is the purpose of the Foley during the vesicourethral anastomosis? And that is a very good point that you brought up because I didn't get a chance to talk about it. But the Foley catheter is mainly used to identify the urethral stump. So in surgery, normally the urethra collapses on itself. And when you want to do the suture to connect the bladder to the urethra, it's very hard to identify these boundaries, and the Foley will allow the surgeon and the surgeon assistant to identify where to make the suture bites.
It's going to complement how well we differentiate all the tissue types since we last discussed this piece of the group. Yeah, all the subtle hue differentiation and texture is all there.
Thank you, Lydia, and thank you for all my professors' feedback on that.
Can you just talk to us a little bit about the gold and purple suture and the
Sure. So the question was about the figure C, about that specific suture. So during the surgery, I observed there was a unique double arm suture where two separate sutures were knotted prior to the surgeon making a bite. And they will work concurrently in counterclockwise motion and clockwise motion. So they start from the 6 o'clock position and make their way around to the 12 o'clock position. And that is how the connection between the urethra and bladder is created. Awesome. Thank you so much, everyone. I would now like to introduce my esteemed colleague, Carolyn Chen.
All right, well, thank you, Terry. My name is Carolyn Chen, and the first procedure I'll be presenting today is left carotid endarterectomy, where plaque buildup is removed from the carotid arteries. My thanks to Dr. Yingwei Lum for feedback and the opportunity to observe. Starting with my sketches, an incision is made over the anterior border of the sternocleidomastoid muscle. The platysma muscle and carotid sheath are divided, revealing the internal jugular vein. The facial vein, branching off, typically lies over the carotid bifurcation and is ligated and divided. The internal jugular vein can then be retracted laterally, revealing the common, internal, and external carotid arteries, as well as the superior thyroid artery. The arteries are looped, and the internal, common, and external carotid arteries are clamped in that order. An arteriotomy is started in the common carotid artery with a number 11 blade and continued into the internal carotid artery using pot scissors. A vascular shunt is then inserted. Using a Freer elevator, a standard endarterectomy plane is created. The plaque is carefully dissected from the intima and is transected at the proximal end using pot scissors. An eversion technique is used to remove plaque from the external carotid artery. After the primary piece of plaque was removed, any remaining debris is carefully dissected off of the arterial walls. To close the arteriotomy, a dacron patch is applied with simple, continuous sutures. The shunt is removed prior to closure. Finally, a drain is placed and the sternocleidomastoid muscle is closed over it with simple interrupted sutures. Continuous deep dermal sutures are applied, and continuous subcuticular sutures are used to close the incision. For my final illustration, I rendered 3 steps highlighting the removal of the plaque. In A, the carotid artery being incised. In B, the dissection of the plaque off of the intima. In C, the plaque being freed. I now welcome any comments or questions.
I love how detailed and clear these are. I was wondering, we were talking about the thyroidectomy, and this, I think, would probably have similar challenges for seeing it in such a small area. What sort of references did you use in addition to the surgery to do a good job with such a tiny little area?
Yeah, absolutely. So the question was what sort of references and material I used to reconstruct the steps of the procedure for the final illustration, since the operative field would be quite small. And to answer your question, Elise, it is quite small. I was lucky enough to view multiple endarterectomies with Dr. Lum. In addition, there are videos and atlases, as well as images of cadavers that I was able to reference to sort of reconstruct this view. I will say during the actual procedure, it's quite easy to see the carotid artery because in clamping and creating the arteriotomy, it gets slightly lifted out of the carotid sheath, so it's removed from the blood and other stuff that you would see in surgery. Yeah, so it was a little challenging, but I was able to get it in the end.
Carolyn, this is very nicely done. I appreciate your use of realistic color, but also the conventional colors. This is for projection.
Yes, this is for slide format.
This is standing back.
All right, thank you, David.
And I think that the brightness of the colors is also exquisite. One suggestion I have is to lessen the contrast on your the other instruments surrounding the main, is where the scissors is on your main image. Some of the retraction and things like that. Just less contrast there so that it can on the artery and stand the scissors cutting. I think that would just help the stories more.
Thank you, Jenny.
Nice job. I like the way that you isolated the ENC and you take them out of the room so you can focus. I know that your pot scissors in the V are really well drawn and angled perfectly to show the cut they're making, but they're getting a little bit lost. I would add a little more reflective light on the under, just strokes and light on some of the under parts of that instrument to make it a little bit higher contrast so you can see it. It's not going to take much to really.
Thank you, Corey.
And I don't know this procedure well, thank God, but in the A, where you sort of, I think that's like the outline of the plaque under the decimal, is that what it looks like? You can sort of see where the plaque is, or is that you sort of communicating to the viewer?
Yeah, thank you for the question, Dr. Stone. The question was whether or not in image A, the plaque would be visible in the operative view the way that I have it drawn, or if it's more of a didactic tool to show where the plaque is within the artery. And there is a didactic tool that I use. I kind of ghosted in the shape of the plaque and the way that it would be removed during the procedure. So you wouldn't be able to see it from before the arteriotomy has been made. And that being said, I have taken some artistic liberties as well with the shape of the plaque. It wouldn't be perfectly segmented like that. It would be continuous throughout the arteries, which is why during the procedure, it's important to feather off the ends when you transect the plaque and remove that initial stump.
I think it's up to you describe the carotid arteries in the order.
Yeah, absolutely. So first of all, thank you, Jiyoung. And the question was, is there a reason that the arteries are clamped in a particular order during this step, which is the internal, common, and then external carotid artery? And the answer is yes. Because the internal carotid artery ultimately supplies the brain and the external supplies the structures in the face and neck, it's important to clamp the internal carotid artery first to prevent any plaque from being dislodged or embolized and potentially causing complications later on down the line. Thank you for the question. The second procedure I'll be presenting today is a laparoscopic ovarian cystectomy and endometrioma resection performed by Dr. Anya Frost. Thank you, Dr. Frost, for your feedback throughout the process. This illustration was created as an overview of the procedure for a general audience. Ovarian cysts can occur as a complication of endometriosis and are filled with dark menstrual blood. They can be surgically removed by draining the cyst and removing the wall of the cyst to prevent recurrence. The ovary is then reconstructed. Moving to my sketches. This sketch shows the port placement for the procedure. The camera is inserted through the umbilicus and points toward the patient's feet. The patient is placed in lithotomy for this procedure. In this case, the cyst is on the patient's left ovary. Adhesions anchoring the cyst to the surrounding organs, such as the bowel, will be dissected in order to remove the cyst. Endometriomas within the peritoneal cavity are excised using energy. Here, the right ovary has been suspended so that a gunpowder lesion can be resected from the peritoneum lying underneath. Bowel adhesions are sharply dissected with scissors. An incision is made on the cyst using energy, and the fluid from the ruptured cyst is removed with section. Using needle drivers and forceps, the wall of the cyst is carefully dissected from the ovarian cortex with continuous peeling motions. The cyst wall and resected sections of peritoneum will be placed in an endo-catch bag and removed. Simple continuous sutures are then used to reconstruct the ovary, taking care to minimize the amount of dead space within the ovarian cortex. For my final illustration, I chose to render the steps highlighting the removal of the cyst wall and the reconstruction of the ovary. Diagrammatic insets showing a cross-section of the ovary before and after the cystectomy are included as well. Here is a closer look at the top half of the image, showing the removal of the cyst wall from the ovary, as well as the insets, and the bottom with the reconstruction of the ovary and the reconstructed ovary in context. I now welcome any questions or comments.
So, two lovely, beautiful images in all these photos and pointed out the tissue reaction that I saw in your sketches and you translated over into pulling that system away from the computer. It's eye-catching. It's well done, and I'm glad to hear that you separated these out because the slide doesn't project well. So it would be my advice. The first one is a bigger slide. The second one is a bigger slide. That's probably like.
Yes, thank you for the compliment, Tim. And you're right, that was exactly my plan. So the full image can be presented as a poster, but it can be split into 2 slides as well.
change their mind. Great to work with you as always around on this, and I want to compliment the layout in particular here. You've done a wonderful job of guiding the viewer through these complex steps, and also just by outlining the two representations of the cyst on the left and allow the viewer to make comparisons of how much it's strength at the time, the role of the nerve cyst wall, and bringing all those pieces together. Again, it's a very specific piece, and also your use of selective color to focus on areas and really highlight areas of interest. You've done a fantastic job.
Great. Thank you so much, Lydia. It was great working with you on this. All right, if there are no other questions, thank you so much for your time. I would love to introduce my classmate, Hannah Forward. Thank you, Carolyn. The first procedure I'll present on is a transmetatarsal forefoot amputation performed by Dr. Ronald Sherman. This is an overview of the surgery created for a lay audience. Forefoot amputations are often performed on diabetic patients who have developed gangrene. Here, I show a before and after illustration, as well as an inset demonstrating how the angle the bones are cut at allows patients to walk more naturally post-amputation. Now onto my sketches of the procedure. First, a deep circumferential incision is made just proximal to the affected area. The metatarsophalangeal joints are then disarticulated. The collateral ligaments are severed and the periosteum is removed from the metatarsals. The metatarsals are then cut with a sagittal saw angled inferiorly. Flexor tendons are severed with a scalpel and the bone is removed from the field. The wound is then debrided until no gangrenous tissue remains. The wound is then irrigated with saline solution. A running locking suture coapts dorsal and plantar intrinsic muscle layers to create a muscular sling over exposed bone. Figure of 8 sutures reapproximate the dorsal and plantar flaps. Skinplasties are performed at the medial and lateral edges of the wound. The skinplasties are closed with a running locking suture. This procedure was especially interesting for me to observe because of the novel use of cod skin to cover the wound. A cod skin graft is prepared to be attached via 2 simple interrupted sutures in contralateral corners, and then a running locking suture around all 4 edges. The running locking suture adheres the skin graft to the edge of the wound. Once the procedure is complete, the graft is tightly adhered. As the wound heals, the graft will become epithelialized. This diagram depicts the angle of the cut bones, which allows for ease of ambulation. For my final piece, I illustrated 3 key steps of the procedure for a hypothetical journal. Figures 4 and 5 demonstrate the removal of the metatarsals, while figure 6 focuses on the application of the cod skin graft. I now welcome any questions or comments.
Piece, really enjoyed your sketches are just magnificent and final product. My question actually is about the husband. Do you know how long it takes for it to be epithelial?
I don't know the exact time scale. I know that it re-epithelializes faster than a human or pig donor skin graft, just because there's no viral transfer, or no known viral transfer at least, between human and fish. And so it's not as harshly treated chemically before it's applied. So it does heal faster generally, but I don't know the exact time frame, sorry.
I do have a question about the layout on this piece, and everything about it is lovely. It just seems to me like the paragraph is just too lingering. Reworking it a little bit. An inset or but just I think that it warrants a little bit more attention.
Mhm. Yeah,
It's gorgeous.
thank you, Anne.
Yeah, a little body of text and describe something about the costume. What would you thought about hanging it out there?
Yeah, so the question was why I chose to place the cod skin graft where I did in the piece. And my thought was I wanted a really clear before and after, a really clear association between what the cod skin graft looks like before application and then after application. So I placed it directly above the step 6, just so that association would be instantaneous. But I can see perhaps moving it a little closer to 5 just to imply that timeline a little better.
And so mostly when we were looking at this, I really like how you took the viewer forward to show the sort of opening procedure happening there. You might be able to enlarge things so you can really take the same. I know that you really try to show that. And that would really take us in. You've already gotten rid of the rest of the field. You can go larger. So that would take you in and back out. And then maybe on 6, you can take us back in to show skin graft. Maybe with a little bit less of a foot, again, larger. You would draw the viewer out a little bit. You want to do it, and also show you.
Yeah, I agree. Thank you, David.
6, margin of 5 and
Mhm. Thank you, Tim. All right.
Really nice one. Didn't be able to. I think in the discussions earlier about
Mm.
is that
I believe I show it a little more clearly here, but it is obliquely such that when the patient walks and rolls their foot, the angle of the bone is parallel to the ground, so that you get that really smooth rotation of the foot and just easier walking. Mhm. All right, thank you. Sneak peek. All right. For the second procedure I'll present today, I chose to observe a robot-assisted nephroureterectomy performed by Dr. Nimish Singla. In a nephroureterectomy, the kidney and ureter are removed in one piece, usually to treat invasive endothelial cancer. First, the patient is placed on her left side. 4 8mm ports and 1 12mm assistant port are inserted. The camera faces the right kidney for the first half of the surgery, but will be rotated toward the bladder later. During this operation, the right kidney and ureter will be removed, sparing the adrenal gland. Once the ports are in place, the white line of Tull is incised from the hepatic flexure to the pelvic inlet. The colonic contents are then able to be medialized. The duodenum is cauterized and also moved medially. The peritoneum is then incised at Morrison's pouch, mobilizing the liver. The proximal ureter is identified, separated from the gonadal vessels, and clipped. The kidney and ureter are then freed from the psoas fascia and any attachments to the inferior vena cava. The renal hilum is identified.
and the renal artery is isolated from surrounding tissue. The renal artery is then stapled first, followed by the renal vein. The paranephric fat is carefully separated from the adrenal gland. All remaining attachments to the kidney are incised, and the kidney is fully mobilized. The gonadal vessels are then divided. Rotating the camera towards the patient's feet, the ureter is freed down to the bladder. Once the ureter is fully mobilized, the distal ureter is also clipped. The bladder is then entered, and a suture is placed in the bladder wall to provide tension for the following steps. A wide bladder cuff around the ureteral orifice is created. The ureteral tumor in this case has invaded the detrusor muscles of the bladder, so a wider cuff is necessary to achieve negative margins. Once the tumor is removed, a 2-layer cystoscopy is performed. The specimen is placed in an endocatch bag, then removed through a widened assistant port. Once the field is clear, a standard pelvic lymphadenectomy is performed, sparing the obturator nerve. For my final piece, I chose to illustrate a slide showing the removal of the ureteral tumor from the bladder. Figure 10 focuses on the creation of the bladder cuff, while Figure 11 illustrates how the bladder is closed. I have also included a cross-section of the bladder to demonstrate the extent of the tumor's invasion. I now welcome any questions or comments.
Marvelous. I know it's gone through a lot of revisions, and so I just want to compliment you on final product because it looks fantastic, and especially the use of the inset of the cross section to show the extent of the tumor that's being resected. I think really helps the piece. And lastly, I'll just say that I do like the way that you have used contrast to really focus the viewer on the action while still maintaining really beautiful color and tissue texture.
Thank you, Jenny.
That comment from Jenny. I'm just in awe of sort of theatrical lighting that you have. It's close. Some background, cool background.
Thank you, Tim.
I think it's a really beautiful piece and very clear. Your background color is perfect. Sorry, I didn't catch this earlier, but it's a quick fix.
Oh, no.
The box, your ureter is clipped, but it looks like the clip is open and just present together.
Okay. Thank you, Corey.
All this or if you use the background color in some of your value shading and some of the instruments, and it just pulls all together. Just sort of a lost and found color approach. You make use of the background, some of the light instrumentation.
Thank you, Tim. All right. Thank you for your feedback. Next, I'd like to introduce my classmate, Alex.
Hello, good afternoon. Thank you, Hannah. We're almost there. So today I will be presenting a proximal hypospadius repair performed by Dr. DiCarlo. I illustrated the final stage of this multi-stage repair. Hypospadius occurs when the urethral plate fails to close during development, resulting in the urethral opening being a bit more proximal than normal. This condition causes issues with urination and later reproduction. So it's important to correct it. It's normally corrected before the age of 2. The goal of this stage of the surgery is to move the urethral opening back to the tip of the penis. So to start, the skin is marked along the borders of the neourethra and the surrounding penile skin, and then degloved using electrocautery. On the dorsal side, the skin is separated along the inner pupus. A wedge of foreskin is removed from the ventral side to create a furlet flap, which ensures a smooth glans following the glanoplasty later. The remaining skin, indicated here in blue, will be used to form the new urethra. The edges of this new skin are freed laterally from the corpus cavernosum, and the medial portions remain attached for perfusion. An artificial erection is induced to assess for any residual curvature or chordae, which is corrected if necessary. The first layer of the urethroplasty is closed with continuous subepithelial sutures starting distally and moving proximally, and then if possible, the urethroplasty is secondarily closed with simple running sutures. To reduce the risk of fistulas and to support healing, the tunica vaginalis will be relocated over the urethroplasty site. To do this, first the testicle is located and the spermatic fascia is divided to access the tunica vaginalis. The tunica vaginalis is divided along the dorsal surface and mobilized to the external ring with a broad ventral pedicle left for perfusion. The testicle is then returned to the scrotum and fixed back into place using a single subepithelial suture, and the dartus tissue is closed with simple running sutures. The pedicled tunica vaginalis flap is tacked over the urethroplasty site using simple interrupted sutures along its border. Now we begin the skin reapproximation. The glanoplasty starts with one epithelial suture, followed proximally by 3 additional subepithelial sutures. And then the dorsal penile skin is sutured to the mucosal collar of the glands with interrupted epithelial sutures, followed by suturing the ventral penile skin to the glands. The penile scrotal angle is identified and marked, and a subepithelial tacking suture is applied bilaterally at that junction to prevent telescoping or skin transposition. The scrotal and ventral penile skin are closed with subepithelial interrupted sutures, starting at the penile scrotal junction and moving outwards. These sketches were designed for a hypothetical journal layout, and I illustrated the creation of the neourethra in full color formatted for print. I now welcome any comments or questions.
These are so beautiful and there's so many of them, it's really impressive. You mentioned that there were multiple steps to this procedure. Could you clarify about that a little bit?
Yeah, thank you, Elise. The question was about the multi-stagedness of this procedure. Because this condition is often associated with severe penile curvature, the first stage is focused on straightening the penis and making sure that there's enough penile skin so that they can afford to lose a little bit when they do this wrap around to make the new urethra. So this is either stage 2 or 3, depending on how severe the curvature was at the beginning and how much skin they had to work with. Thank you.
And echoing the comment about how many lovely steps to the procedure that you presented. I will say it's now, and I'll say it to the whole group, because I know it was born. The transitions in these presentations are phenomenal, and in and of themselves are extremely instructive. So they've well done, everyone. I think in this piece, just a few highlights, just more distinction on the tissue. Just a comment. This is for projection.
This is for print.
So this is thought, especially when the exposed areas, and I think that bring a little more attention to the area of action. But
thank you. I appreciate it, Anne.
Yeah, this is such a nice series. I think what I agree with Anne. I think that the contrast in between the cavernosa could be a little bit stronger. I know that this is projection, we're probably not seeing exactly what it looks like on the screen, but we also have to allow for printing. Just be careful not to let it go too dark, because it's so much nice tissue that actually light up that interior area and not just a little bit. I want to make a comment on your sketches and also really for all your classmates as well. It's so much fun to see the different style sketches come through. And for those of us in the audience who are not illustrators, one of the challenges is to come out of the operating room with observations of not only the steps but the tissue reaction. And even though we encourage all of you to spend time with your sketches, they then reworked and they all struck that balance between enough information to show the surgeon feedback I do, but also still room to change if there's change that needs to be. So I definitely want to compliment you, Alex, but also all of the classmates and really clean sketches and recreation of just the right amount of information.
Thank you, David, from me and my classmates, I'm sure. All right, if there's nothing else, I appreciate your feedback and we will move on to the radical cystectomy with intracorporeal neobladder creation. This surgery is performed laparoscopically with the Da Vinci robotic system, and I want to extend a special amount of gratitude to Dr. Higgins, Dr. Cates, and Dr. Patel for all of their feedback during this complex illustration. This procedure is typically performed due to bladder cancer. So the bladder will be removed along with the prostate in male patients, and a new bladder is created using a portion of the small intestine. The remaining bowel is repaired. This will allow the patient to urinate through the natural orifice with some degree of continence. My procedure is illustrated on a male patient. The abdomen is insufflated and the ports are placed for the camera, robotic arms, and assistant port. The one port will be upsized later to accommodate a second assistant port. The patient is initially placed in full Trendelenburg. To orient yourself, we are looking down at the bladder towards the feet. The peritoneum is incised to identify the ureters, which are mobilized to the level of the bladder, clipped and divided. A standard pelvic lymph node dissection is performed, and the superior vesicle or obliterated artery is clipped and divided. Denon-Via's fascia is incised so that the ductus deferens and the vascular pedicles of the seminal vesicles can be located and divided. The lateral vascular pedicles of the prostate are located and divided. Then the urachus is cut and blunt dissection is performed in the retropubic space to mobilize the bladder. The lateral pedicles of the bladder containing the inferior vesical arteries are also divided. The dorsal venous complex of the prostate is stapled and the urethra cut with curved scissors. The bladder and prostate are then bagged for removal. The patient's Trendelenburg position is reduced to 20 degrees at this point, and a marker is placed 15 centimeters from the ileocecal valve to indicate the most proximal point of the ileum that can be divided. A loop of the ileum is then brought down to the urethra. A Rocco suture is used to secure the ileum to the recto-urethralis muscle, and a neurourethral opening is made at the apex of the loop of ileum. The urethroplasty is completed with a double-armed running suture. The ileum is divided approximately 20 centimeters from the apex on the left and 25 on the right using a straight stapler. To repair the remaining bowel, a small hole is made at the stapled end, and a side-to-side anastomosis is performed with the distal ileum remaining inferior. The neobladder is formed by opening the bowel along the antimesenteric side bilaterally, and the posterior plate is sutured, with the right side being brought down in a dog-ear fashion to create a larger posterior template. The anterior plate is closed halfway. The corners of the right side are connected to the anterior suture line to form a rounded bladder dome. The ureters are brought into the lumen of the neobladder, partially divided, leaving a mobilization tab on the posterior side and spatulated. The anterior ureter is sutured with interrupted sutures, then the mobilization tab is removed and the posterior ureter is sutured similarly. With the ureters implanted bilaterally, the rest of the anterior neobladder is closed horizontally, starting laterally and progressing medial. The completed neobladder is filled with saline to check for leaks before final closure. The surgical procedure was illustrated for use in slide or video format. The main steps of the neobladder creation and ureter implantation are shown here, including suturing the posterior plate, suturing the anterior plate, ureter implantation, and the completed neobladder. I now welcome any questions or comments.
Remember sleep.
Yes.
some ways I was taken back by the more appreciated step-by-step sketches, because you grayed out certain areas, left certain areas white, brought in flat color, some instances, and helped the viewer understand where we were going, what we were doing, where, you know, what was the action to the next slide. As beautiful as these are, there's beautiful tissue action, highlights, like form. So I guess my point is that each of these has great value, and I hope you don't lose this or you know, not carry this forward into professional life with the ability to tell a simple story or a complicated one with limited resource or all the resources that you.
Thank you, Tim.
Beautiful. I really enjoyed the sketches. I just wanted to say, everyone's sketches really capture emotion. But I really love the little splash of red. Really felt inside. Quite a bit of depth, but also quite a bit of focus on what you want us to focus on. Soft brush. That translated really well to color. Probably be a lot of sketching.
Thank you. I appreciate the compliment.
Really amazing. Well, I just want to say in general, you know, it is really just such a joy to have you guys in the OR as students. It is one of the most special and inspiring, you know, parts of being a surgeon here at Johns Hopkins. And so thank you guys very much for, you know, adding to our life in the way that you do. Is this surgery in MBI?
Yeah, this was on a mail.
So I know, I appreciate this because the way that you have illustrated it is an android pelvis, right? That depth of the male pelvis, I can tell just by looking at your image that this was done in a man as opposed to a kind of point shaped pelvis. So I really appreciate your attention to that detail. But I guess the only question I have is the right ureter. Is it intended to go over the ilium in that way, or should it be behind it?
I'm not sure I fully understand the question.
I understand there's a weird optical illusion where you have your cecum. I'm sorry, I didn't catch it earlier. Not your cecum, your appendix looks like it's part of the appendix looks like it's continuous.
Oh.
Because of the curve. Yeah, you can, that's a quick fix.
Yeah, I appreciate you pointing that out.
I also want to just say, I have to agree with everyone about the beauty, that the main things that I'm looking for in these pieces, and you all students know, is clarity and accuracy, and nailed it on all fronts. The educational, you know, quality of your sketches is fantastic.
Thank you. And I wanted to say to Dr. Stone, thank you, and to all the other surgeons for making us feel welcome. It was a delightful experience.
I just want to say I hope you can work with me on this, because not only is it an amazing procedure, but you handled it in such a professional way. We tackled your line work with all the background research. It was as if it was just flow naturally out of your brain. It's wonderful to see the combination of all the training that you've had in the past 2 years just be so fruitful. And also just the way that you took on to great lengths to build up the three-dimensionality of your background by practicing ZBrush and everything was very impressive. One thing you lasted through, we should find out when you could.
Oh, yeah. I don't know which ones.
Yeah.
Click through them slowly for you. I appreciate the compliment, Lydia, and all your help. It was a really fun surgery. I love any surgery that has origami.
I'm so proud of all the students. They have come to a successful conclusion of both OR sketching and surgical illustration. They did a great job. I do want to thank the faculty in our department, the surgeons who have permitted the students to observe and then have, worked with them to correct their sketches and make sure things are accurate. I also want to thank Kelly Burnett, who helped us out with our, she's the educator who did our OR orientation for the students, really important. And you did a great job and you had them feel really comfortable on the first days in the operating room. Thank you very much for that. I want to thank everybody who attended in person today and also folks who are watching online. I'm Corey Sandone. I'm the course director for this surgical illustration course and the director of the of the Department of Art as Applied to Medicine. I hope everybody can join us for a reception in the lobby. So thank you very much and congratulations to the students.